I have to look it up more, but I remember like there was like the poison like originally from the 1800s, like when making the hats. So I guess like hence like the Mad Hatter Party. So I guess like one thing that kind of stood out to me was like at one point Alice was like sniffing sugar, but like it could have been like potentially like other substances like cocaine or something because like their eyes like were dilated. They're like very like elevated and mood during that part of the party. So that was just something I had thought about when watching the movie.
Right. So a few things going on here. So during the actual party, you observed Alice to be sniffing sugar.
Sure, yeah.
Yeah. So there's zero chance that was sugar. From a clinician's perspective, not so much. So sugar does have a street name, or sugar is a street name for cocaine. Okay. So if Alice were to be snorting cocaine, which I think we all believe she actually was, what are the signs and symptoms then that we would look for with regard to acute cocaine intoxication other than dilated pupils? So you said her pupils were dilated.
Like the rabbit, like his eyes were dilated.
Okay.
Tachycardia, hypertension.
Yeah. Right, you mentioned the excitability.
Right.
Yeah.
Good. Yep. So on psych shelves, cocaine intoxication is clinically indistinguishable from a panic attack. Right? So there's no way you can tell the difference. The way you'll tell the difference, if a question writer deemed it necessary to give you that clinical vignette and put both in the answer set, is some evidence of the physiologic trauma of snorting cocaine. So the most common are nasal septal erosion, good, or even perforation.
Yeah.
Right, so those would allow you to say cocaine intoxication and skip over maybe choice A, which may be a panic attack. Let's talk about panic just a little bit. Panic attack is itself clinically indistinguishable from an acute MI. So any psych shelf in which somebody presents looking like they have a heart attack, but there's no electrocardiographic evidence of myocardial ischemia, that's panic. All right, so you'll get an EKG, you'll get serum enzymes, and both will be normal. Maybe sinus tachycardia on the EKG, but that's it. Certainly no flip T waves, no evidence of ischemia, and the troponins will be normal. So ruling out heart attack, single best answer would be a panic attack. Cocaine can induce both. Right? Cocaine can induce a panic attack. In that case, it's cocaine intoxication. Cocaine can induce an acute MI as well. Any young person presenting with an acute MI should be worked up for acute cocaine intoxication and have that on the very top of the differential. So maybe both Alice and the rabbit with regard to acute cocaine intoxication. What else do you want to discuss pertaining to the Mad Hatter Party?
Well, I have to look up the history more, but I thought like the reason why they call it like the Mad Hatters because they used like some chemical back in the day, like when making the hats that like caused them to, I guess, have delirium or like some type of like mental decompensation. Mm-hmm. So that was like one thing also I was thinking about when watching that scene in the movie.
Mercury.
Exactly what it is, right?
Yeah.
So mercury was actually put into the rims of the hats. Mercury was absorbed, and there were case reports of individuals, quote unquote, going mad, being known as the Mad Hatter, with regard to psychosis and delirium. Mm-hmm. That's mercury poisoning. So certainly the party itself, the Mad Hatter Party within Alice in Wonderland, looks at toxin exposure. Remember, toxins are considered substances. When we talk about substance-induced mental disorders, that does include the toxin-induced mental disorders as well, with mercury as an example. The heavy metals are what you're going to be concerned about. Middle right periodic table, if I remember correctly, from 3 decades ago. Heavy metal poisoning. You mentioned the word delirium. We probably should define this. Separating from psychosis just a little bit is a condition in which the individual conforms to what the DSM will publish as the 4 Cs, DSM-5 the 3 Cs. All right. So with regard to the DSM-5 diagnosis, you have a significant change in cognition. The course is defining as being acute in onset and fluctuating, which helps differentiate from psychosis. And by the way, in cognition, one example of cognition could be perceptual disturbances, so psychotic features count. And the final C is that the cause is always, for lack of a better word, organic, right? Due to an underlying medical condition or the direct physiologic effects of a substance, and that includes toxins. So while not really at the top of our list with regard to the workup for a patient who is delirious, heavy metal assay is definitely a part of the differential. So that's the Mad Hatter party. Any other thoughts with regard to that scene?
What's the personality of all the different characters there? I mean, I think, the Mad Hatter certainly has like that outsized personality, quite a bit of odd behavior, eccentric thinking, but then all the other characters attending the party seem to have their own like idiosyncrasies that they bring to the table.
Mm-hmm. And here, I think it's important to make a differentiation between character traits we observed that prompt discussion of maybe personality disorders versus diagnosing personality disorders in a character. Because the latter, actually coming to a diagnosis about a personality disorder in any of the characters in this Disney film would be difficult given that these behaviors appear to be in the setting of substance abuse or substance dependence, now known as substance use disorder. And it's only in the context of sobriety that the clinician should feel comfortable identifying character traits as being from the person versus induced by the substance. So we could definitely pick out a salient trait and allow it to prompt a discussion about a personality disorder, but that would be different than actually diagnosing a personality disorder in the character if they were to hypothetically present to us in clinical practice. Because again, I think this case study is ripe with discussion of substances. I have no idea who's sober here.
Speaking of substances, since this is a tea party and they're drinking tea, I was wondering if tea could be thought of as another kind of substance, maybe alcohol, and kind of influencing them that way. Since we mentioned sugar equating to cocaine.
So I think, what you're getting at is tea metaphorical here, and if so, what's in our differential? Alcohol certainly, I don't know if there's such thing as a Long Island iced tea when this the book was published. That said, there is a common substance of abuse that is usually made into tea. Yeah, the hallucinogens, right? Class of substances. Hallucinogens are very commonly so, and nobody would have any difficulty. Yeah. Yep. So we kind of referred to that last week. You weren't here, but we kind of referred to that last week. But suffice it to say, the hallucinogens are very, very commonly brewed into teas, especially for medicinal or even shamanistic rituals. So that could certainly be going on here. While the Mad Hatter Tea Party is certainly something that I think most of us quickly think of mercury poisoning, we shouldn't exclude the tea in the tea party, right? Because it might actually be hallucinogen. Ayahuasca, as you said, and other similar substances, shrooms as well. Final thoughts on the tea party? Other characters, other scenes you want to discuss?
Well, I had another thought. Like the scene with like the hookah with the caterpillar, like that was also like at one point they show her kind of like inhaling something like, or I guess we can assume it's like tobacco or who knows, it could be like laced with other things as well. But they show her at one point inhaling it, and then I guess just like as a general like my impression of like Alice, like to me she seems like very easily distractible, like. She's like running after the rabbit, and then at one point she kind of like comments on like her inability to like focus on stuff. So I was like wondering, like, could she even have like ADHD or something like that, like a hyperactive ADHD?
The difficulty there would be deciding again if we are going to take this as a case of polysubstance dependence or the diagnosis formerly known as polysubstance dependence. What came first, the chicken or the egg? We could certainly look at Alice as, especially if you wrote the prequel, as having ADHD. It would make sense then, at least neurobiologically, that she would abuse cocaine, maybe self-medicating with the stimulant. That could certainly be the case. Of course, if it is, or whether or not it is, has everything to do with the prequel, right? If we see a drug-free Alice who is not on this trip, what would she look like? What would we observe as her behavior? And if she continued to be inattentive and hyperactive? Sure.
Yeah, I would say for like the smoking of the hookah, like I definitely think it represented more than just like the traditional hookah of tobacco. But like he also the like caterpillar seems very much to be in a very relaxed state and just kind of wants to sit around. So I was thinking more of like marijuana being indicated.
Yeah, and with the observation of being as calm as that caterpillar was, cannabis has to be at the top of our differential diagnosis, and of course can be inhaled through the hookah. Absolutely. Yep.
Right. Yeah.
So acute cannabis intoxication has both behavioral as well as physiologic sequelae. Behavioral, very commonly, could be paranoia as well as panic, not seen in the caterpillar. On the other hand, the physiologic signs and symptoms that define cannabis use or cannabis intoxication is actually remembered by the acronym THC, right? So tachycardia, hunger, and there are 2 C's. Any guesses as to what they are?
Conjunctivitis.
Yeah.
Conjunctivitis.
Yep.
Conjunctivitis.
Again, I mentioned this in last week's Periscope as well. Any conjunctivitis on a psych shelf is going to be cannabis intoxication until proven otherwise. The other one is cottonmouth, right? THC. Forgetting his eyes. At all bloodshot, I'm forgetting them.
Oh.
It's definitely wild. It's like
Yeah.
rings of color. I mean, I
Yeah.
certainly think suggestive of it.
Mhm.
Actually, it might actually.
I
Some
think
of them
it
actually
might, but
yellow
I'm wondering
with-
now if I'm just like making that up in my head. Let me look.
You look it up.
I mean,
All
I
right.
haven't got it right here.
Go for it. All right. For those following at home, especially those addicted to Disney students, none of what we're talking about right now will be on your midterm yet. The actual substance of abuse that I certainly want you to remember for purposes of this discussion, we have yet to get to, or yet at least to expand upon. All right, so no worries from that end. I know we're covering multiple substances, and I'm discussing multiple intoxication syndromes, but I do not get concerned yet. Yeah, you'll hear my cue when we start to discuss something that you will be responsible for. Which leads us to our conversation. What else do you want to talk about here?
LSD,
Why LSD?
because this is Alice in Wonderland.
And it's actually that easy. So let's talk about LSD. Alice in Wonderland is an LSD or acid trip, right? And that's certainly what this film, this book, this tale is really about. LSD, similar to hallucinogens and related substances, that includes cannabis, have both behavioral and physical sequelae with regard to acute intoxication. Unlike cannabis, and we hadn't talked about it yet, LSD has no observed or identified withdrawal state. So do not worry about any withdrawal states pertaining to LSD despite chronic use. The behavioral manifestation of acute LSD intoxication looks like a panic attack. Again, clinically indistinguishable from panic attack, and therefore looks very similar to what you might expect from cocaine, amphetamines, or other stimulants. And I think I misspoke. I said behavioral, physiologic. I meant panic, of course. The behavioral is interesting. The behavioral actually, I think is usually termed, I like to actually frame it as the psychiatrist's prednisone. So you hit the four major spheres of behavioral defect: dysphoria, mania, anxiety, psychosis. All four. Now there's a fifth one too that commonly presents on exams and is really good to remember. It gives you some historical perspective with regard to where this drug came from, and certainly a present perspective with regard to identifying this drug or this drug syndrome on an exam. And that is the fear of losing one's mind. All right, so it could present behaviorally like a chameleon. I mean, it really is protean. But the fear of losing one's mind is very typical of LSD, especially when LSD is dosed, meaning the individual takes LSD without their knowing it, as a date rape drug or similar acting. Fear of losing one's mind. So let's go back a little bit to the history. This was a legal, with an L, drug that was synthesized by Sandoz Pharmaceuticals. It was, I'm not going to even talk about the military. It was actually used by psychiatry in the 1960s, microdosed within psychotherapy. Matter of fact, there's a great HBO special, I don't have the name, starring Rock Hudson, his narrating his own biography and how LSD therapy saved his life. During the 1960s, unfortunately, a counterculture basically took over the drug, and Congress had to act and illegalize it, and that all medicinal use came to an abrupt halt, and only till recently has it started to be used again for medicinal purposes by psychiatrists. One of the things that happened that resulted in this drug being made illegal by Congress, 1968 or so? No, I was not born, right? Well, kind of was, but I was really small. Was that there were people who were jumping from roofs under the influence, especially, again, when they did not know they ingested the drug. Bad trip. So again, we look at this as, when microdosed, individuals who are of a positive frame of mind, like you actually go to an office, ask for help, aka a chief complaint, know that you're being microdosed, and with that therapeutic milieu, life-saving, check out Rock Hudson's biography on HBO. On the other hand, the direct opposite, if you're dosed, if you're given this as a date rape, the intoxicatory effects are going to be horrifying. Fear of losing one's mind. There's actually a great, it takes a little time to find it on the internet, a little bit more difficult than you'd expect, but there is a great write-up with regard to a Sandoz employee who, as part of being employed by Sandoz, skewed 2-week paycheck, microdose, they actually gave it out. Tested it on himself. By the way, what I just said was stated, I don't know if it's actually proven or known, but it's quote unquote known to have been part of your Q2-week paycheck. Right? One person though who worked for Sandoz, actually did test it on himself, and on his ride home had horrifying, vivid, both auditory and visual hallucinations as he rode home on his bike, and that day is actually called Bicycle Day. You can actually find it on your calendar. He gets home, he writes a letter of his horrifying experiences. The letter looks like it's written like in somebody's wrong hand with a crayon. I mean, in terms of his altered state of consciousness. That kind of effect resulted in a very famous person's daughter allegedly believing she could fly. What we do know is that she died after falling from a roof under the intoxicatory effects, acute intoxication of LSD. And because of his status, Congress got involved. I want to say around 1968 or so, it was made illegal because of that person's death. So any movie in which you are struggling with the supernatural, sci-fi horror, or just sci-fi, and wondering, is this an Alice in Wonderland adaptation? If you see anybody jumping from a roof, boy, are they giving you a little bit of a historical nugget that perhaps what you're looking at is an artist, writer, director's impression of LSD, its history, as well as its signs of intoxication. Can you name such a movie that really is a remake of Alice in Wonderland? 1990s?
Limitless?
The Matrix.
Almost.
Oh.
Well, this is good too. That's a good too. But The Matrix, yeah. I mean, the jump program, he fails, right? Very historically accurate. Matrix. Matrix is an alternate reality. It's an LSD trip. And by the way, LSD has more than one reference in that movie. So if you didn't know, they hand it to you, right? Morpheus basically tells you. By the way, Morpheus, to get Neo to unplug, gives him a choice. What choice does he give him? Red pill or blue pill, right? If Neo takes the red pill, he goes back, or not, sorry, blue pill, he goes back, right, into the Matrix. Red pill, he gets unplugged and he sees reality, right? He takes the red pill, and of course we know what happens. Under black light, LSD happens to light up blue. I do not know if the producers intended that, but it's chemically accurate. Right? The blue pill is LSD.
And isn't that a reference to one of LSD's names, like a couple of scenes right before, like they're talking in a club and someone's offering, can't remember which name.
I thought it was ecstasy that they offered. I haven't watched The Matrix in a little bit. I have to double check that. Well, what we do know is how does he get to the club in the first place?
The White Rabbit.
He follows the White Rabbit, right? So let's check that. I have to check that. But he follows the White Rabbit. So there again, there's more than one reference to LSD in The Matrix, and that is simply a remake of Alice in Wonderland, right? which is that acid trip. We see distortions of time and objects, very consistent with not only the acute intoxication. Remember, in addition to the behavioral and the physiologic signs, perceptual disturbances as well. And these perceptual disturbances are likely due to surges of dopamine. And as a result, especially I think it's the dopamine, either 1A or 2A receptor. No, it's the two. It's a subgroup of the D2 receptor. Anyway, any antagonist to that receptor will help with the perceptual disturbances. And haloperidol is a great example of that. And that's whether or not the perceptual disturbances occur within the context of the acute intoxication period or months to years later as a flashback. Haldoll's single best answer. Again, I want to say it's dopamine 2A, but we'll double check that. What are some other hallucinogens that are chemically related to LSD that you know? I think we mentioned a couple of them before.
Ayahuasca.
Right, psilocybin, which are shrooms and ayahuasca, are definitely two. Right, psilocybin I think is referenced in this film, the mushrooms. No doubt about it. Psilocybin, in terms of intoxication versus, again, no withdrawal, but in terms of intoxication, to my knowledge, nothing to distinguish it from acute LSD intoxication.
What about the length of time of the effects?
I have to look.
I think it's like 6 hours for psilocybin and 12 for acid.
Oh, okay.
So 6 and 12. Again, not a whole heck of a big window there to distinguish.
PCP count?
No, I'm not going to count it. It comes from at least the American Psychiatric Association discussing PCP. It comes from a different category of or structural category, and therefore a different chapter in the DSM, albeit one that still is included as a hallucinogen, right? Whereas LSD has its own chapter, PCP is under other hallucinogens in terms of the chapter title. And therefore ketamine, right? Because that's structurally similar to ketamine as well. So yes, ayahuasca and psilocybin are really the top two with regard to the tryptamines that are chemically related to LSD. But we'll keep it focused on LSD. Again, I definitely need you to know the acute intoxication signs and symptoms, both behavioral and physiologic, and that they can also be manifest with regard to use of similar acting medicinals and or drugs, and that there are no signs and symptoms suggestive of withdrawal. Fear of losing one's mind, right? Jumping from roofs. What else from Alice in Wonderland as a case study? Any other behaviors here?
Just like the Red Queens as the
yeah, I was
poster
gonna say.
subjects, like there's definitely either like a personality disorder component to it. Like you can see there's like narcissism to it, but then there's also just a violation of others' norms, the way she treats other people.
Right, and this was the reference, and I apologize for the periscope. That wasn't the periscope from this morning's discussion pertaining to the breasts. Just to recount very quickly, in the episode called The Breasts, I believe it's season 6 of Seinfeld. It's 5? 5? Thank you. 5 and 5, got it. Episode 5, season 5. We actually have a couple of things that I wanted to reference. The first of which was that a quote-unquote patient in the psychiatric hospital jumped. And that's certainly, again, anytime you hear somebody jump, you've got to think LSD. Now, in terms of a straightforward analysis or straightforward depiction, there's no reason to suggest that the individual was under the influence of LSD. He was in an inpatient facility. People can have contraband, but no overt part of the script per se, although somebody did bring up this morning that the children, quote unquote, believed he could fly. So from that context, that is consistent with what many believe to have been the cause of death with regard to the use of PCP, the belief you can fly. If we needed something else to just reinforce that or support that, to think that maybe PCP, you got me thinking PCP, LSD were a central part of that episode, you have Elaine's comment off with her head, which directly, absolutely directly, relates to and alludes to Alice in Wonderland, and specifically the Queen of Hearts, right? So here we are with the Queen, and this is how we got here, right? Definitely linked to this morning's discussion. So you see some behaviors that I'm hearing you believe are cluster B? That's what you said. So what are the cluster B personality disorders?
So histrionic, borderline, narcissistic.
Antisocial, friends of the 4. Every time we study the personality disorders, I would strongly encourage you to not only think of them in terms of clusters, the way the American Psychiatric Association classifies them, but also in terms of 2 other groups with a different definition. The defining quality here would be those that adhere to a cardinal trait versus those that don't. Because if you remember that, there's only like 2 that don't. All the others do. And once you get there, if you look at that first column of all those personality disorders that adhere to a cardinal trait, if you understand that cardinal trait, you will never miss it in a clinical vignette. There's no reason to review or especially memorize the DSM criteria, because those criteria are nothing but examples of that cardinal trait. So now focusing on the cluster B personalities. Which one do you want to take first?
Borderline.
Borderline. So unfortunately, the first one you chose happens to be one that is in that other column. There's not one trait that we can just embrace and say, and in order to be diagnosed with borderline, individuals will need 5 criteria from blank, right? So we've got to come up with some strategy to remember what the actual criteria are so as to recognize them on an exam. The best way to memorize those, to teach those, I think, are to look at the defense mechanisms that define borderline personality, because just in case your question writer may in fact ask the defense mechanisms, and if so, you're prepared. So common defense mechanisms in borderline include splitting, right? All or nothing thinking. Can you guess the clinical criterion that results from splitting?
Someone is
Dysfunctional relationships.
That's probably an indirect, no doubt.
Self-interest activity.
Nope.
someone's either good or bad.
And that's exactly right. And what does that usually result in that is actually a diagnostic criteria? Mood lability, right? One way or the other, all good or bad, no middle ground. Individuals who split and split as a character trait will often devalue and then perhaps even go to the other pole as well, right? Devalue versus, I'm trying to think of it's a clinical term they usually use. Unfortunately, it's not overvalue. But there are those mood swings as a result. Individuals are either the best doctor ever or you are the worst doctor I ever met. Idealization, devaluation. Splitting. Second defense mechanism. Passive aggression. Passive aggression is the inward turning of a nihilistic impulse. So one of you guys hates your attending. That is an id impulse. That's real. Your superego, thanks to your mom and dad, will not allow that impulse to come to conscious awareness. Therefore, you will not act on that impulse. Of course, this is going to cause internal conflict, subconscious conflict, that way back in the last century, Freud termed anxiety. That hate is going to be processed, if you will, by an ego defense. And if the ego defense happens to be passive aggression, that hate is going to be turned inward. So passive aggression is thought to be the defense that underlies the suicidal behaviors and gestures defining of borderline personality. Anger turned inward. By the way, I just gave another one away. Anger happens to be a DSM criterion. Not a defense mechanism per se, but you could tag team it with passive aggression. Nihilistic impulse such as anger turned inward, resulting in suicidal gesture, suicide attempt. Dissociation is the other common one. Dissociation is a rapid but temporary change in one's affect, allowing them to go from an unfavorable state to a more favorable one. And we're going to talk a little bit more about that and give some examples when we go to another personality disorder. But for our purposes here, dissociation is actually not only a defense mechanism, but it's a diagnostic criteria too. So 3 diagnostic criteria, add on anger, and you, I think, have 4 of the 10 right there. You're 40% there. Right. All of which result in impaired interpersonal relationships. Next, cluster B personality.
Cluster B, narcissistic.
Narcissistic, and that does adhere to a common character trait. Individuals who are narcissistic are arrogant. They believe they are special, and they believe only individuals as special as they can understand them. Then when you look at the DSM criteria, you read them one by one. They are but examples of that cardinal trait. So much easier to remember. And that quality really does easily distinguish it from the borderline personality. Number 3, histrionic. Histrionic individuals need to be the center of attention. Individuals who have histrionic personality need to be the center of attention. Now, let's talk a little bit about how to differentiate that from the grandiosity and arrogance of the narcissist. In each case, the individual comes in mismatched. They feel, with regard to who they are, self-esteem, something's like this. It's a mismatch, that you are above them. And this is a subconscious notion. So they need to do something to even the playing field. The individual who has histrionic personality disorder will often talk about things in such a way to always make themselves the center of attention as a one-upper. And no matter what you say, even when what you say is prompted by their question, they have an answer for it. And their answer usually begins with the word I. They always got to be the center of attention. Now, this is normal, both verbally and non-verbally, if the individual is a child. And many of you may have nieces and nephews. I think you might be a little too young to have sons or daughters, but nieces and nephews will enter a room. And when they're not the center of attention, which is usually almost all the time when they just enter a room, they will just start dancing. And unless you pay attention to your 4-year-old niece or nephew, they will continue to dance until you say something. Oh, look at them. That's when they actually stop, right? So that's histrionics. Now, when your niece is 4 and does that, it's cute. When your friend is 24 and does that, how does that make you feel?
It's not cute.
No, it's not cute, all right? It's not cute. So that's histrionic personality disorder. And, it gets verbally too. So a person can walk into a situation. Again, it may be age appropriate when younger, but certainly it could be age inappropriate too when it's our age, well, your age and my age. When the individual, upon a normal conversation, keeps on one-upping you, right? Or, very commonly, when somebody tells a joke, they're going to tell one that's funny. Ah, boy, I got one. They didn't even bother laughing at yours before they're all over it. I got one. Me next. And I've seen this happen. It happened to me once, where among several people, somebody began to tell a joke and clearly had no punchline. They just had to be the center of attention. And the joke went on. I remember my brother-in-law turning to him and said, are you going to make a point? It actually happened, right? And again, as a psychiatrist, I knew exactly what was happening because I had observed the behavior for a good couple hours previous. And there was a diagnosis there, histrionic personality. I'll never forget my brother. There might have been an explicative in there as well because it was just a run-on joke, right? Stories too, tall tales. There's a point where usually a friend knows that this didn't happen, right? And you're 10, 15, 20 minutes into the story and it's all anticlimactic, right? So there's that sense of embarrassment that's the countertransference that is quite characteristic of individuals who are around somebody afflicted with histrionic personality disorder. The narcissistic, not even close. Same mismatch, but their arrogance gets them to a point where they cut you down to their size. So instead of conflating and making up things for the histrionic, it's the arrogance and the cutting down to where they are. And that's an absolute different feel. It's a different countertransference. That's where the arrogance comes in. Very cutting. Last one we have is the antisocial personality disorder. Yes, there is a cardinal trait. It's a blatant disregard for and violation of others' rights. Unlike the other cluster Bs we talked about, unlike any other disorder within the personality disorders we discussed, the antisocial personality is an adult-only illness. Okay. All the others can be diagnosed in children, not antisocial personality. And as part of that, the individual must have demonstrated conduct disorder prior to the age of 15. Cruelty to animals, destruction of property, truancy, disregard for authority, teachers.
So there's actually a question we had on rounds related to what happens if you identify antisocial personality disorder in an adult with that history of conduct disorder.
Hypothetical, person presents to you. We'll call him Ted Bundy. And there is, only because we discussed him before, and there's no doubt that this gentleman's behavior is very consistent, if not defining, of a blatant disregard for and violation of others' rights. There's little argument there. Having said that, hypothetically, let's say that we talk to the patient themselves, we talk to collateral who knew him the best, and there is zero evidence, and reliably so, of conduct prior to the age of 15. Then what? This is where the term psychopath is usually used, right? Psychopathy, right? And there's a couple of ways to view psychopathy, but one way is that there are individuals who are antisocial but are not mentally ill, right? They're engaging in illegal behavior, and their behavior should come to the attention of law enforcement, not psychiatry. Remember, psychopathy is a clinical term, yes, by psychologists and psychiatrists alike, but it is not a diagnosis, it is not a mental disorder. Antisocial personality is. And what the evidence-based literature suggests is that if you have these signs and symptoms and have been diagnosed with or have evidence of conduct prior to the age of 15, your outcomes are different than if you have the same exact signs and symptoms, maybe even a monozygotic twin, with the same exact signs and symptoms without such evidence. So that's why one is a disorder and the other one is a clinical term used to describe behavior. All right, so those are your cluster B personality disorders. Given what we just discussed, the Queen of Hearts, what do you got?
Borderline. Yeah, I could do.
On borderline?
Yeah. I have strong fear of abandonment. Because she tries to kill Alice after assessing her as a threat.
So why not antisocial?
I think because it comes from a place of, I think because it comes from the fear of abandonment, because she's worried that Alice is going to steal away this other person, whose name is escaping me. But it's basically to prevent this person from leaving her by killing the threat.
And then hypothetically, if that fear were absent, you don't think the Queen of Hearts then would demonstrate this blatant disregard of Alice's rights by attempting to kill her?
I think she would. I mean, it seems like everybody who works for her is scared of her, you know? So I think she's probably been demonstrating a fair amount of violation of people's rights without that.
Well, so what you're demonstrating here is a teaching point that is not likely to get on an exam, but one that will definitely appear in clinical practice. And that is, remember, these illnesses that we're talking about, and now the two specific are the borderline personality versus the antisocial, are part of the same cluster. And the reason why the American Psychiatric Association uses the word cluster has everything to do with there being clustered and shared signs. People's behavior always, well, not always, very often, almost always, defy categorization. It's exactly what we're talking about right now. So in our case formulation, we may say that she actually is presenting with a clinically significant personality B cluster, the differential diagnosis of which will be antisocial versus the borderline personality. Definitive diagnosis will bear whether or not her true motivation is due to abandonment concerns and fears versus that which is not related to abandonment issues. It remains to be seen. Before we end, any other thoughts with regard to any other characters in Alice in Wonderland?
I just had a follow-up thought on the Queen. I mean, I guess like one other consideration might be like a primary mood disorder, because like she's like painting the roses, kind of like goal-directed activity. She's like kind of irritable, so like maybe possibly like a bipolar, like manic type of behavior. She's like kind of emotionally labile.
So if that is the case, and it might be the case, then what we just discussed really now takes a lower position in our differential. That is, we can't or shouldn't diagnose any personality disorder during any active axis 1 pathology. And if there's any concern, this may be a manic episode. And if there's any concern then that her most likely diagnosis is a bipolar 1 disorder, we have to reserve our discussion for any personality disorder to a lower differential, right? So again, with regard to bipolar, again, bipolar 1 is defined through mania. If an individual has mania, they have bipolar. Of course, when I say this, implicit is that it can't be due to a substance or a medical condition. That's implicit. Beyond that, there is only one other condition ever described in which an individual has had a manic episode, but the single best diagnosis isn't bipolar 1. Any thoughts of what that condition is?
Medication induced?
Well, substance induced or GMC, that's implicit. The other one is called schizoaffective disorder, bipolar type. And in that condition, the individual has full-blown mania, but will not get a diagnosis of bipolar 1. Schizoaffective, bipolar type. We'll talk more about schizoaffective and the psychotic disorders in a separate discussion, but I just wanted to mention that as the outlier. So mania equals bipolar 1. That means that in bipolar 1, the individual may or may not have alternating depressive episodes. If they do, they do. But if they don't, they're still bipolar 1. Right? Mania defines bipolar 1. So what happens when you have someone who gives you a history, past psychiatric history of a manic episode and tells you that they seem to actually alternate with panic attacks? What diagnosis is that? Bipolar 1, excellent. What if, carrying on from our previous conversation, the individual tells you that they've had mania and it seems to actually alternate with episodes of transvestic fetish? Bipolar 1. All right, you got this down, right? Right. All right, so that's it, right? Again, the only time, and read the vignette closely, where that wouldn't be the answer is that if it's schizoaffective bipolar type. Good. So that's certainly something that we have to look at the queen, in this queen. Again, metaphorically, is the queen seen in any scene as CENE, where she's digging?
I mean, she seems distractible to me. She's very, like, high energy, like in the way she talks, like very pressured speech at certain moments.
She definitely could be manic. Again, I think when you look at the actual depiction and signs and symptoms, I think that's got to be interdifferential. And to the extent that it continues to be interdifferential, personality disorders are now pushed to the bottom. Is there any scene where she's actually digging up anything? The reason why I say that is because metaphorically, dig fast is what we often remember as the actual acronym explaining or describing those signs and symptoms of acute mania. And boy, would it be a perfect fit if there was a scene in which she was digging. One movie that I think is a rather straightforward depiction of bipolar that actually has the main character dig, albeit it's a brief scene, is Field of Dreams. It fits in real nice. I mean, it took somebody in my audience to point it out and find it, screen capture it, send it to me, put it into the PowerPoint, but I did it. It got there. All right, so the queen, we have to now think that this might be a bipolar 1 illness. All right. Any other closing observations before we cut away? We're good? All right. I'll be posting very soon the films to watch for next week. For those of you following along at home who have received the Zoom link, in about 10 minutes, we'll be live again with our case conference. Until then, we'll see everybody next week. Thank you.